That was like truly the organizing chairman's words. Without further ado, ladies and gentlemen, it's our great pleasure to introduce our distinguished chairperson for the first session, the young and dynamic Dr. Pranav Radkar. We are appreciative of your presence. He is a humble human being. Dr. Pranav Radkar is MS MBBS consultant at Photon Eye Center, Bayaner. He has done fellowship in cornea and advanced cataract surgery with years of experience and a plethora of accolades. He definitely deserves to be on the dais. Dr. Pranav Radkar, Dr. Lata Pohare, MBBS, PGD, MES, MBA in hospital management, practicing since 30 years, and practicing since 30 years gynec and general medicine at Ozone Clinics, Mahadunge and Baner NX. She's a highly respected general physician with a unique expertise in facilitating seamless communication amongst the patients. As a primary care physician, her clinical and communication skills are par excellence. She has earned a lot of trust and admiration of her patients. I would request you to please introduce the first speaker.
Colleagues and friends. Here, welcome to Dr. Sayali. She has completed her MBBS from Sane GS Medical College and
Hello.
Good morning to all dignitaries and all my friends and colleagues. Dr. Sayali has completed her MBBS from Sane GS Medical College and KM Hospital, Mumbai. She did her post-graduation in ophthalmology, followed by a long-term fellowship in cornea and anterior segment from prestigious LV Prasad Eye Institute. At present, she is consultant cornea, cataract, refractive surgeon at Dr. I. Agrawal Hospital, Aundh, Pune. Expertise in corneal transplantation, keratoconus, dry eye diseases, ocular allergy, chemical injuries, and ocular surface diseases. Welcome to Dr. Sayali.
Thank you, ma'am, for the kind introduction. Good morning, everybody, and I'll be starting with probably the most localized subspecialty which is going to be talked about today. So I'll be giving an overview of corneal diseases and what all treatment options we have. I have no financial disclosures. So it is said that eye is window to the soul. But all philosophies aside, we can definitely say that eye is a very, very complex organ and with lot of intricacies to discuss about. So there are various interfaces through which the light has to pass smoothly to focus on the retina to give us a sharp and wonderful imagery that we see. So ophthalmologists are always equated with mostly cataract surgery, refractive errors, and refractive surgeries. But today we'll go past that and we'll discuss about a subspecialty of ophthalmology, which is very close to my heart, that is cornea and anterior segment. So cornea is the first interface through which the light passes. It is the outermost, anteriormost transparent coat of the eye, which is, because of its transparency, smooth surface, and normal curvature, the light can enter the eye smoothly to give us a sharp image. So cornea is actually a multi-layered tissue. So if we do the histopathology, it starts with the epithelium at the most anterior part. Then the widest portion is filled with stroma, and the posterior most layer is filled with endothelial cell layer. So if we divide corneal diseases, we can roughly divide it into shape abnormalities, then corneal swelling or opacification, infections, inflammations, and finally trauma. Let us go with the first disease, keratoconus. So if you see, the healthy cornea is a smooth spherical structure, if you see it from the side. And if you see in the next image, when a spherical cornea assumes a conical shape because of inherent weakness in the stromal tissue and starts protruding anteriorly, starts becoming more and more thin, it is called as keratoconus. So if you see the central picture, if the patient is looking down, the lid is also taking the conical shape because of very advanced conical change. So a typical keratoconus patient when presents in a clinic, they are always young adults. They are around 20s or 30s, second or third decade. They always present with blurred vision, glare, and they are always unhappy with their glasses. They have been frequently changing their glasses. They are still not happy, and they have very high cylindrical powers. So when we see such a patient, we suspect keratoconus. Also, a most common association, if you ask them that they have had allergies in the eye, they have rubbed their eyes during some period of their childhood, or they are still rubbing their eyes. And rubbing of eyes is a very, very important factor associated with this disease. So why I chose this disease as the first? Because it is not so uncommon. In a routine OPD, I usually see one new patient every single OPD. So the prevalence reported in studies is 1 per 200. And it is more common in males. It is usually present in both eyes, but sometimes asymmetrical. It hugely affects the quality of patient's life because all these patients are young adults. It affects their professional life, academic life. And it is very important to detect this early because it is a progressive condition. So to detect this early, we have this imaging technology which gives us even subclinical diagnosis. So if you see the picture on the right side, the central brownish zone is the area where the cornea is becoming thin and protruding. So what are the treatment options for this? So one aspect is to stop the progression from happening so that the disease gets arrested in the same stage as when it is diagnosed. So for that, we have a procedure called as collagen cross-linking, where we strengthen the corneal stroma using UV light and riboflavin. So it's a short procedure done in the OT, but it gives this, it strengthens the collagen and further progression is reduced or completely stopped in most cases. Along with that, we have to tell the patient not to rub eyes because that is going to be counterproductive. The next aspect is to improve their vision. Because their cornea is abnormal in shape, the glasses cannot give them good correction of vision. So we need to use special contact lenses which are hard in material and they take up they form the new normal surface and improve the patient's vision. In advanced cases, we may resort to corneal transplantations. So these are the few surgical options which are available, and in the most advanced cases, corneal transplant has to be done. This on the left-hand side, a procedure which was actually invented at Dr. Agarwal's Eye Hospital. That procedure is called CARES, where you can see this bluish segment of corneal tissue you can see that has been implanted in the cornea in the area of the cone to flatten it and to normalize the shape of the cornea. Let us move towards the next topic, which is corneal transplantation, which is also called as keratoplasty. So corneal transplantation means replacing diseased cornea with a clear, transparent, healthy corneal tissue from a diseased or dead human donor. It can be of two types: full thickness conventional corneal transplantation, where we transplant the entire cornea, and lamellar corneal transplantations, where we selectively transplant only the layer which is affected. So indications of full thickness keratoplasty include the full thickness scars, like in this case, where we have replaced the scar tissue with a new cornea and patient has there is visual restoration as well as clear cornea has been restored. Next indication can be, this is actually a patient who was 55 years old and she had bilateral corneal opacities because of a genetic condition called as macular corneal dystrophy. In her both eyes, corneal transplantations were done and she got back her vision. So other indications could be a non-responding severe corneal infection, where to debulk the infection we have to replace the cornea. Corneal perforations forms another indication, where there is a huge perforation which has developed in cornea, and to secure the integrity of the eye, we have to seal that space with a new corneal tissue. So the next type of corneal transplantation is endothelial keratoplasty, where the transplantation of only endothelial cell layer is done from the donor cornea. Why we prefer to do only endothelial transplantation is that it becomes a highly selective procedure. Patient has to take the foreign tissue only in the form of a very thin layer. And this is the procedure of choice in corneal endothelial diseases, where the rest of the tissue is normal. At present, because of most common indications, this is the most commonly performed keratoplasty. So you can see in the left-hand side, the cornea has become swollen and edematous. So in this patient, a thin layer of corneal donor tissue was transplanted. In the right-hand side, it has been stuck on the back of the cornea with the air bubble pressure. And in the lower scan, you can see the inner thinner layer of the tissue is the graft. What are the advantages of endothelial keratoplasty? Because the foreign tissue or the allogenic tissue is very less in amount, the rejection rates are very low. It is a closed globe surgery and there is no, the globe integrity is preserved. And there is faster vision recovery. Other indications are similar to the macular dystrophy which we saw. There are certain other dystrophies where this surgery is performed. So this is the latest advance in endothelial keratoplasty, which is even thinner corneal tissue can be transplanted. And the advantage, the most specific advantage of this procedure is that even a young donor can be used to transplant the tissue. So this is the next type of transplantation where only the stromal tissue is transplanted, leaving behind the patient's or host's endothelial cell layer. This is done in scars which are very superficial, where the endothelium is normal and we just need replacement of the anterior tissue. This is also the case where anterior layer of the cornea is normal, so we have only transplanted the stromal tissue. So in general, outcomes of corneal transplantations are very good. At the end of 1 year, above 80 to 90% of eyes are still having very good clear grafts. And because of relatively isolated location of the graft and avascular nature of the area, the acceptance rates are very good. So the most crucial element in this is donor cornea. So almost anyone can donate the cornea after their death. Only when there are infectious diseases or sepsis or HIV positive cases, then only that person cannot donate. So only after a person's death, the cornea can be donated, and it needs to be retrieved between 6 to 10 hours from death. So let's go to the corneal infections. Due to proliferation of microorganisms in the corneal tissue, there forms a surface ulcer and stromal necrosis, and the ulcer develops. So this is an ocular emergency and can be potentially vision threatening. So typically the symptoms would be lid swelling, red eyes, a white patch will form on the black surface of the eye, patients will present with pain, blur in the vision, and predisposing factors most commonly are trauma, contact lens wear, a foreign body, exposure to dirty water, diabetes or poor hygiene. So usually whenever possible, we take the sample from the eye of the patient, send it for microbiological workup, try to get the organism, and then we get a more clear idea of how to treat the patient. So most common organisms are filamentous fungi, gram-positive cocci, gram-negative bacilli, etc. So the most important message that I would like to drive here is that whenever we see a corneal ulcer or suspected case of corneal ulcer, we should not be starting the patient on any steroid eye drops, because most infections flare up or become worse with starting of steroid eye drops. We just need to give a broad spectrum antibiotic, frequent antibiotics, and refer the patient without starting any steroids. So these are some of the examples where with a patient and systematic treatment, the ulcer which is there in the left-hand side has healed and a scar has formed. So even after healing, depending on the location of the scar, a visual acuity may still be affected after resolution. So these two patients are also, both are contact lens wearers, currently under treatment. Both of them were wearing contact lenses without much care and have developed these ulcers and responding to treatment. So this is a perforated corneal ulcer where we have had to continue the treatment, seal the perforation with a medical grade glue, and also achieve the result of a scar. This is a typical herpes zoster ophthalmicus infection. So they also have a high chance of recurrences. They need to be treated with oral medications also. So sometimes when infections do not respond to any medications, we have to debulk it using a keratoplasty. So next is autoimmune corneal diseases. So there can be a lot of manifestations in the eye, like dry eye, peripheral corneal ulcers, non-infectious corneal perforations, and a lot of conjunctivitis where there is a lot of scarring. So we shouldn't be just isolating ourselves to the eye. We should look forward and see other findings in the patient's body elsewhere, like these, where they could be having conditions like rheumatoid arthritis or SLE or mucous membrane pemphigoid. So only eye medications are not enough in these conditions, and we have to take rheumatologist's opinion and workup to start systemic immunomodulators. So next is chemical injury of the eye. It is a true ocular emergency without wasting any time. Wherever the patient is present, we have to first do a thorough cleaning of the thorough irrigation of the eye using any fluid which is available actually, but Ringer's lactate is preferred. So irrigate all the area around the eye, inside the eye, all corners of the eye, so that the chemical effect is nullified, and then patient needs to be immediately referred. So when a patient presents with chemical injury, usually this is the picture in a case of very severe injury. So what happens in that is the black circle where I have drawn it, that is an area called as limbus, from where the epithelial cells of the cornea grow out. So that area is very badly affected in any chemical injury, and eventually after acute phase is over, the eye becomes something like this, that the conjunctiva starts growing on the cornea and cornea doesn't remain transparent. So in this condition, when the eye has become quiet, we have to perform a procedure called as simple limbal stem cell transplantation, where we take help from the patient's other eye, which is a normal eye, and then take a small area of limbal stem cells, cut them into these multiple pieces, lay them over the corneal surface, and slowly, slowly the cornea can become clear like this. So it takes a lot of time for achieving that outcome, almost 6 to 8 months, but it has to be done in a stepwise manner. So this is also another injury, a 10-year-old boy. The front of the cornea and rest of the area looks normal, but if you look under his eyelid, there is a Chuna plaque which is sitting there. So it will lead to continuous ocular surface inflammation and needs to be removed. Coming to corneal trauma, can be in the form of corneal lacerations or globe rupture, commonly with sharp penetrating objects. So first step is to secure the globe by suturing the wound as any other wound, but because globe is a fluid-filled organ, it has to be done as soon as possible. So wait for the wound to heal with sutures to stabilize and the wound to strengthen, and then whatever other things are happening inside the eye, like a cataract formation, has to be taken care of, and then we can still give a good visual recovery to the patient. So take-home messages. So cornea is a delicate part of the eye, crucial for clear vision. Most important message that I keep giving to the patients is do not rub eyes, because they keep doing it and then someday they'll end up in a lot of complications. Either the cause is itching or they have just got the habit, so both need to be eliminated. Frequent change in glasses, blur vision, high cylindrical power, suspect keratoconus, do workup. Corneal transplantation procedures have evolved greatly over last few years to become more selective, less invasive, and even more successful in terms of visual outcomes and survival rates. Never start steroid in a microbial keratitis patient. And immediate irrigation of the eye surface with Ringer's lactate, most crucial in case of chemical injuries. Thank you.
So, thank you, Dr. Sayali. It was wonderful, actually, giving an overview of cornea. I think few things which definitely need attention is the frequent change in glasses, which often is reported to any general practitioner or any medicine. The other thing is corneal ulcers. And the next thing probably would be chemical injury. So these are the three things which probably come to a general practitioner in a general way, and they need attention. So thank you very much for covering it up well. Thank you. Any questions? I think we can take up if at all we have time, but we're happy.
Surely it was a value-adding talk. I would request the chairpersons to please felicitate the speaker. Sane, we need to felicitate you. Never mind. Requesting Dr. Prashant Patil sir to felicitate Dr. Lata Pohare and Dr. Pranav Radkar, please. Dr. Prashant Patil sir from SPDA.